Good morning, everyone. I am Dr. Amit Pathania, and today we will be talking about management of mild symptomatic patient. We will be discussing about the case definition as per WHO, how do we assess severity of illness, and management of mild symptomatic cases. According to WHO case definition, they are classified into possible, probable, and confirmed case depending upon clinical, diagnostic imaging, lab, and epidemiological criteria. Clinical criteria: any person with at least one of the following symptoms: cough, fever, shortness of breath, or sudden onset of anosmia, aguesia, or dysgeusia. Diagnostic imaging criteria: radiological evidence showing lesions compatible with COVID-19. Lab criteria: detection of SARS-CoV-2 nucleic acid in a clinical specimen. Epidemiological criteria: at least one of the following two epidemiological links should be there: close contact with a confirmed COVID-19 case in the 14 days prior to onset of symptom, or having been a resident or a staff member in the 14 days prior to onset of symptom in a residential institution for vulnerable people where ongoing COVID-19 transmission has been confirmed. So, based on these, possible case is the one who meet the clinical criteria. Probable case is the one who any person meeting the clinical criteria with an epidemiological link, or any person meeting the diagnostic imaging criteria. And the confirmed case is the one any person meeting the lab criteria, that is COVID positive. Symptoms of mild disease: children may present with influenza-like illness, but they do not have respiratory difficulty in the form of rapid respiratory rates, chest indrawing, or hypoxia. Cutoff for rapid respiratory rates, fast breathing, are less than 2 months, it is 60 breaths per minute; 3 to 11 months, 50 breaths per minute; 12 to 16 months, it should be less than 40 breaths per minute; and more than 5 years or more than 60 months, it is 30 breaths per minute. There should be no lower chest indrawing. Oxygen saturation is more than 94% in room air. Some cases may have no fever or have only GI symptoms such as nausea, vomiting, abdominal pain, and diarrhea. Physical examination may show congestion of the pharynx, but no auscultatory abnormalities. In mild cases, child is usually cared at home, but sometimes admitted in COVID care facility. Thorough education of parent, caregiver need to be done if the child is cared at home, which we will learn in subsequent slides. There is no established therapy as of now, so supportive care is the mainstay. Infection prevention and control measures should be followed at all steps for all suspected and confirmed cases. The child with mild COVID symptoms can be taken care either at home or COVID care center. The doctor should assess the feasibility that a child can be cared at home. The child should fulfill the following criteria: mild disease as assessed by doctor, have the requisite facility at their residence for self-isolation and also for quarantining the family contacts. A caregiver should be available to provide care on 24/7 basis. A communication link between the caregiver and hospital. They should download country-specific tracking app, like for India, it is Arogya Setu app. Attendant agree to monitor the child and regularly inform child health status to the district surveillance officer or doctor. And parents or attendants agree to fill in an undertaking on self-isolation. The aim is to keep the high-risk patient under medical supervision. All the medical and social issues should be taken into consideration before sending the child to home quarantine. In the event that the child tests positive for COVID-19, she may be eligible for home isolation only if the response to 1ABC or and 2A to E are all yes. So, one is eligibility criteria for home isolation. A is Respiratory rate should be less than a specific cutoff. Room air saturation more than 94%, and there should be absence of all of the following high risk features, that is infants, cardiovascular disease including hypertension, diabetes, immunocompromised states, chronic lung, kidney, liver disease, cerebrovascular disease, or if the child is obese. Second is social eligibility criteria for home isolation. So, all should be there, that is 2A is the patient has a requisite facility for isolation at his her residence and also for quarantining the family contacts. Caregiver is available to provide care on a 24/7 basis. Country specific app should be downloaded on mobile, like for India it is Arogya Setu app, and it should remain active at all times through Bluetooth or Wi-Fi. The patient has agreed to monitor his her health and regularly inform his her health status to the home isolation. Patient has filled an undertaking on self-isolation and shall follow home isolation quarantine guidelines. Child should be cared in COVID care facility if home isolation is not feasible, that is small house, overcrowding at home, high risk patients staying at home, and inadequate facility. Regular monitoring not possible due to any reason, or if the child has high risk factors, that is immunosuppressed, chronic diseases, they should be admitted in hospital for monitoring and care. All children at home isolations or COVID care facilities or hospital should be cared in a child friendly environment, and parent or attendant may be allowed to take care with proper PPE kits and precautions. Treatment is mainly symptomatic, like for fever we can give paracetamol at the doses of 10 to 15 mg per kg per dose and may be repeated whenever required. NSAID should be avoided, although there is no evidence against these as of now, but they should not be used. There is no role of cough suppressants. If throat irritation is there, then warm saline gargling may be done thrice a day. Honey is a throat soother. At present, antibiotics are not indicated. Emphasis should be given on proper nutrition. Citrus fruit should be taken. Junk, spicy and fried food should be avoided. Plenty of warm fluid should be taken. Hydration should be maintained at all times. Rest and deep breathing exercise should be done, especially pranayams. Room temperature should be ambient. Though there is a lot of literature on various medication having benefit in COVID treatment, but as of now, no single drug cures the disease. I repeat, no single drug cures the disease. Various drug studies are chloroquine, hydroxychloroquine, ivermectin, antiviral agents like lopinavir, ritonavir, remdesivir, favipiravir, or immunomodulator including tocilizumab, interferon beta, or plasma infusion. Parents or caregivers should be trained to monitor child at home by explaining how to count respiratory rate. They should do at least twice a day and when child is not crying. They should be explained how to look for chest indrawing, nasal flare, to look for bluish discoloration of body, to look for cold extremities, and to monitor urine output. They should use oxygen saturation monitoring by handheld pulse oximeter. They should keep monitoring chart and communicate to doctor, and they should know where to go in case of emergency. Danger signs should be explained. Parents should seek help when child develops breathing difficulty, rapid respiratory rate, chest indrawing, nasal flare, bluish discoloration, reduced activity, lethargy, poor feeding, altered sensorium, seizure, or hypoxia, monitored as SpO2 less than 94%. If sent to home, Parent or caregiver should maintain a monitoring chart as shown, or some simpler format can be used. And when the child is in COVID care facility, they should be monitoring by doctors or trained nurse at least twice a day for vitals, heart rate, respiratory rate, temperature, oxygen saturation, development of chest and drawing, intake output, especially reduce or difficulty in feeding or reduce urine output. They should look for lethargy, seizures, and general activity of the child. Child should be transferred to hospital if there is respiratory distress, SpO2 less than 94% on room air, shock or poor perfusion, poor oral intake, especially in infants and young children, lethargy, especially in infants and young children, or if there is seizures or encephalopathy. Now we will discuss some frequently asked questions. Question is, how many days to isolate the child? And the answer is, to keep child isolated for at least 10 days of symptoms onset and at least 3 days of afebrile period. Further home isolation for next 7 days with health monitoring at home is also recommended. For example, if a patient with symptoms for 14 days, the child can be discharged for next 3 asymptomatic days, that is 14 days plus 3 days is equal to 17 after the date of onset of symptoms. Whether to do repeat tests for COVID? The answer is, if no high risk factors, there is no need to repeat tests to document recovery. What is the risk of transmission of illness from child to other family members? As there may be some risk of transmission, precaution including mask, physical distancing, hand hygiene, isolation should be maintained. Does the child need vaccination after infection? The answer is, as of now, vaccines are not available. It's unclear whether infection provides lifelong immunity or child will be at risk of repeated infection. Will the child have long-term complications? As this is a new condition, long-term complications are difficult to predict. With more studies, guidelines may be developed. When can child be sent to school or play with other children? The answer is, after 14 days of onset of symptom, child become non-infectious, can be sent to school or play in group, provided at both places physical distancing norms are followed if the schools have been allowed to open up. So to summarize, majority of children with COVID infection have mild illness characterized by cold, cough, but no difficulty in respiration, that is respiratory rate less than a specific cutoff. Moderate cases may mimic non-severe pneumonia. These patients can be managed at home with home isolation after assessment. And there is no evidence to suggest beneficial role of antiviral, hydroxychloroquine, tocilizumab or plasma infusion. Thank you.